George, congratulations.
Thank you.
are this year's recipient of the Irvine Page and Alva Bradley Lifetime Achievement Award. And I was wondering, George, if for those listening today, if you could give us some examples of the highlights of your career that have led to this wonderful award.
Well, thank you very much, Karen. I have to say that it's an auspicious occasion to have this in New Orleans, which is where I started my career. And actually, a lot of the work that I have to give credit to started in this town with the help of people both at Ochsner Clinic and Gabby Navarre's group at Tulane. So we really started off in cell culture looking at endothelin and showing that endothelin is produced by mesangial cells in the kidney, and then in fact it's a transmitter, and under diabetic conditions actually plays a major role in the pathology of the kidney. So and from there we actually did clinical studies at LSU where we were looking at, again, diabetes models in the kidney and focusing on changes in albumin excretion rate and blood pressure and looking at different therapies and combining them. And that led to the combination of ACE inhibitors and diltiazem as being preferred over other calcium antagonists for lowering proteinuria and actually preserving kidney function to a certain extent. And then after that, funding became very tight. I moved around and I left the cell culture world and moved more into clinical research and fundamentally got involved with clinical trials and some major NIH and industry trials in diabetes and the African American study of kidney disease from the NIH, Renal. We're currently now, we just finished Credence, which is a diabetes study in the kidney. And I have a very large diabetes outcome trial, Fidelio, which is going to report within the year, looking at kidney outcomes. And again, these are in people with hypertension and diabetes and kidney disease. And that's pretty much what I've been doing. So we really have kind of come full circle. We've done the cellular stuff, we've done studies looking at intrarenal hemodynamics, and now we're really, since 1993, my career has really been focused on clinical outcome trials and some smaller pathophysiologic studies in man.
Well, George, your career has certainly covered the entire spectrum from cell culture to now human studies. And you certainly have your finger on the pulse of the field of hypertension. And I'm wondering, what do you see as the future of hypertension treatment in the patients that suffer from this disorder?
So that's a very good question. You know, we have about 125 different antihypertensive medications right now. And these medications are actually, if you know how to use them and what doses to give and when to use them, are actually pretty effective, assuming patients take the drugs. And I think the way I see the future is not so scientifically sexy as much as it needs to be more focused on education of the patients and really applying what we know, because we know a lot and a lot of it isn't being applied. What am I talking about? For example, we know very well, and it's in all the guidelines, it's been in the guidelines since I can remember, low sodium diet, exercise, weight loss, good sleep will help reduce blood pressure. And in fact, we now know that if you don't adhere to a low sodium diet, there's no point in using ACE inhibitors and angiotensin receptor blockers because they won't work because the system is suppressed. So that sounds very naive and simple, and especially if you're a researcher, you're going to say, come on, doesn't everybody know that? Trust me, they don't. So I think we need to educate patients on the importance of a low salt diet. I think we need to try and help them with the help of dietitians, and I know those are not readily available, but if we can have access to them, we need to make sure the patient understands how to apply a low sodium diet. And we're doing this actually at my center, and it takes time we're not getting paid for. But once the patients see that you're taking the time and they try it and it works, and it will, then what happens is they have more confidence in you. If they have more confidence in you, they're more likely to take the medications that you're giving them, especially if you're responsive to any problems that they may have, and warn them in advance. So I think really the future clinically is to take what we know and start applying it. And if we do that, we're going to have far better blood pressure control than we have right now. So that's number one. Number two, I think we have mechanistically, the last antihypertensive that was approved was in 2006. So there's not a lot of drug development going on in new antihypertensive medications. Having said that, again, I think we have 7 to 8 different mechanisms that can be utilized in combination. And combination therapy has been advocated since 1996. There is a clinical trial called the ACCOMPLISH trial that was published in 2008 in New England Journal, which was an outcome trial showing one combination was better than another. And yet, clinically, physicians are still recalcitrant in using combination therapies. So we really need to streamline the pill count and use medicines that have been proven to be of benefit, not theoretically, not just lowering blood pressure, but actually impact outcomes. So I think that needs to happen. And I think in terms of research, basic research, there's a lot of interactions that are just now starting to be discovered. So what am I talking about? The gut microbiome is an untapped bastion of research that we really are just starting to learn about, and its contribution to hypertension, overall inflammation, and other issues. And I think that's a major area that we need to move into. I think additionally to that, there is a whole separate area of sleep and sleep disorders that affect hypertension and blood pressure variability. And I'm not talking about sleep apnea, that ship has sailed. And fundamentally, if you treat sleep apnea, you get 1 millimeter per 1 hour of the blower. That's not really helping you, let's be honest. But sustained sleep quality, lack of good quality sleep, uninterrupted sleep, less than 6 hours, is, especially in older people, associated with increased blood pressure variability, and so-called masked hypertension, where people wake up with pressures that are okay and they're at home, they're watching TV, who knows, and all of a sudden their pressures spike. And nobody understands that. We have data to suggest that if you reinforce and reinvigorate good sleep patterns and get people sleeping again, so they're sleeping at least 6 to 7 hours, that in fact you can restore better blood pressure control and reduce the variability. In fact, we're just getting ready to publish this. So very important area of research that needs detailed research, because all I'm giving you is kind of the clinical perspective, but the basic science perspective from a CNS neurology standpoint is untapped. And then there's a whole other thing about central pressures, the meaning of central pressures. Are they actually a better predictor? And there's a whole controversy about that. And so the mechanisms of modulating blood pressure in older people. So endothelial cells are not what they used to be when you're 70. Nitric oxide release isn't the same. There's a lot of different things. So and I'm just scratching the surface now. So there's a lot of integrative research that remains to be done.
Well, clearly it's easy to see why you'd be an excellent mentor. And I'm wondering what advice you'd have for somebody who's just starting their careers now in the field of hypertension research.
So this is an excellent question. It's a tough question. As you know, I mean, I'm going to be very honest about this. Funding in hypertension is tough if you're just going at pure hypertension. So you need to link hypertension either mechanistically from an understanding standpoint, or if you're going to do epidemiology or even clinical trials, you've got to link it with some other disease process that is going to be affected by you affecting blood pressure. So clearly, again, if you want to link the gut microbiome to hypertension to outcomes, that's fine. If you want to look at people with diabetes, obesity, there's a lot of work being done in obesity right now. And again, depending on where you want to go with this, not all the questions have been answered by any means. And so you need to find that an area you like. You need to read up on everything that is known in the specific area that you want to do. Not everything, but if you want to do basic science, okay, pick an area of basic science that you're interested in, read that, and then from within, what are the unanswered questions? and start there. And hopefully you're with a mentor that can guide you through that so that you can start creating a portfolio for yourself and build on it with subsequent questions that are being answered. And just like you and I did in our careers. And that's really what you need. But you have to have an internal zeal for this. This has got to be not a job. This has got to be a passion, and it's got to be something that you need to wake up every day and be excited about. The moment that happens, the moment that stops, you're going to have a major problem, because then it is work, and this really is work. It's not just a little work, it's a lot of work, and you're going to get frustrated soon and burn out, so you don't want that. So that's why it's critically important in the beginning to pick an area that's really near and dear to your heart.
Well, thank you, George. That's excellent advice, and I'm sure there'll be a lot of trainees listening to this, and I hope they heed that advice.
Thank you.
Again, congratulations on this very well-deserved award, the Lifetime Achievement Award.
Thank you very much, Karen.
Mm.